Okay, good afternoon. Thank you to have me here. It's my pleasure to be a presenter for the great discussion about the humeral non-union. So I have this case. This case is a 58-year-old female. She fell 6 months ago on her left elbow. And this is the X-ray that I saw when I first saw her. It looked like this. So I just review her X-ray. For the first injury, it's coarse injury like this. And at the initial hospital, the first doctor, he did this. And after the operation, the patient have the ulnar nerve palsy. So the doctor removed one KY. At 1 month, it looked like this. And another KY on the medial side is also migrate. So the doctor also removed the other KY. This is the X-ray at 2 months on the right. Okay, I will proceed. So this is the at 3 months and 6 months. It looks like this. For the examination, physical examination, the patient have the scar at the posterior of the elbow about 8 centimeters. The elbow have deformed, right? Like in the photo on the right, have walrus elbow. And I also palpate the KY. And the motion is on the most right photo. So the patient can move only a bit. And also they have a sign of the ulnar nerve injury. So as this is 6 months, and patient have non-union of the distal humerus and also the ulnar nerve palsy.
So, is this her dominant hand?
No, this is the left hand.
This is the left side, right?
Yes.
Is there any pain on motion?
The patient have pain and cannot use this elbow. Cannot move because he is really painful elbow when motion.
No, what I mean is a painful non-union or is a painless non-union?
Painful.
Painful?
Yes.
Because of the screw or because of the non-union?
I think maybe both.
I think the problem is ulnar nerve injury, right? As you said.
Yeah.
Okay. There are two points. If she has some motion and it's painful, I have to rule out whether this is the pain come from, the pin or the screw. Because the second point is it possible to do reconstruction? Because as I see, there is almost no bone there, right? When you have a non-union which is close to the joint, sometimes you probably need to accept that non-union. But if, as you said, there's a painful, then maybe we have to think what is to treat this. But I don't think I can fix it. And even I can fix it, probably she will have a stiff elbow and she has no motion at all. I don't know. Maybe the other opinion.
Yes. I agree. I think looking at the cause of the non-union, definitely you can say that it was not stably fixed the first time. The problem now, I think, is you have to determine if the ulnar nerve palsy is because of the lateral displacement of the medial fragment compared to the shaft, or was there initial injury with the K-wires, which I think the original doctor was thinking about. So I think definitely she will need an ulnar nerve decompression, and maybe you can medialize the fragment. I think, as Prof mentioned, the capitellar side of the bone is almost resorbed. So I'm not sure if you'll be able to reconstruct this. But I think on the medial side, where the humeral ulnar joint is, you still have a large enough fragment that you may be able to fix it back to the shaft. But you have to correct the translation to decompress the ulnar nerve and at least maybe transpose the ulnar nerve. Just trying to improve on what she has at the present.
Yeah, for me, I have the same idea. But if if I saw this, if I see this film and the patient was open fractures, I will consider about the infection. But this is close, and it during like in the modern surgery, I think the potential of an infection is might not high, but the quality of the bone is bad. It's resolved, so it might come from the school that tackling in the lateral condyle. So I might prefer not, except for the nerve that we need to address. I might consider look for any kind of infection. Is it the lab is still okay, or the investigations, the lab is okay?
Okay, so I will proceed. So the lab is look like this. There are some elevation of the ESR, but cell count is okay.
Kind of
And there are no sign of like a inflammation around the elbow. But for me, I also curious. That's why it's like quick resorption too. And so what I did is I removed the implant. I did the ulnar nerve compression, as Dr. JP said, and I put the patient on the flap. With I opened the window on the posterior. If you see this picture on the right, so because I want to do the wound dressing here, and after I sent for the culture, there are one that positive. That is the PCR for mycobacterial tuberculosis. So what will you do next?
Usually, I don't send for the mycobacterium. Yeah, I usually culture for the some mycobacteria. If the PCR come out with this, so think about host. Is there any immunocompromised, or is that some kind of mycobacterium? This is a mycobacterium tuberculosis. But I usually for the mycobacterium infection is for mycobacterium fortuitum. So I consult the infectious medicine right away.
Yes, me too. I also consult the infectious, and he came for find out the cause. The chest X-ray also normal. So, and the patient have no underlying disease.
May I ask Dr. Pornpanit, in the intraoperative, do you have any clues that you suspect about the mycobacterium? Because we usually not do routinely, right?
The tissue, there is no caseous necrosis, but the tissue is quite soft. It look not normal.
What is their suggestion for infectious?
They just debridement, and they will give the anti-TB drug.
May I ask the intraoperative, what is the motion and instability of this?
Yeah, this part also, there is no stability. It's like a fall motion at the distal part of the humerus. So, any such no.
I mean, the main issue is there is no bone for reconstruction, right? Because if we think we're going to fix with something, there must be a bone that we can fix. But because there is no bone and there's infection, so probably you need to treat infection. I don't know. And then after infection clear up, then you have to check whether there's any bone. And in the meantime, probably I will go for early range of motion.
I agree. Maybe this could be I think you were able to decompress the nerve. Was there any recovery of ulnar nerve function?
Yes, at 2 months after that.
Right. So I think I agree with Prof that initial management is just the anti-TB meds for now. And you may need to add external, maybe a hinged brace to allow range of motion, but add some stability for the construct. And after you treat the TB, then you can consider what your reconstructive options are for this particular case.
I think so. So the worst thing that patient can get is pseudarthrosis at the distal humerus and act like the elbow.
Okay. So what I did is this, because there are some bones in the medial epicondyl, so I don't want it to resolve. So I put the KY to make sure that it will not like a move or have some resorption because the motion. And I also did the research for the anti-TB spacer. So I found that the isonesis can be used at the mixed with the PMMA for the anti-TB spacer. I used 4 grams of this, but in my hospital there is in a liquid form, so I have to contact the pharmacist to make it in like a dye powder, 4 grams of isonesis mixed with the spacer. And so the post-operation is look like this.
What is the piece on the, because there is no capitulum on the...
This is the spacer.
Spacer.
The capitulum is gone. There's no capitulum. Next. So after 2 months, the ulnar nerve have some sign of the recovery, and the EMG also show partial axonotomy. So I did debridement. So I found another infection, but it's like a late growth. So I consult the infectious. So they tell me this may be contamination, but I also did the serial debridement, antibiotic, until it's no growth. So this is like at 9 months of the post-injury. It look like this. The trachea is also still there, but no capitulum. So I think it's time for the definitive treatment.
Did the trochlear fragment heal to the shaft?
No hearing.
If the tuberculosis is treated, would she be a candidate for a total elbow arthroplasty?
Again, please. Yeah, I think maybe, because the PCI is negative now.
How about the pain? Does the patient still have pain around the elbow?
No, the patient have no pain because she was put on the cast. Okay, because the time will run up, so I will conclude this. So what I did is this. I did the trap approach, and because when you have to do the total elbow arthroplasty, so you need the condyle like a reference point, and also it will be like a bone stock to prevent the rotation of the prosthesis. So I lucky that I have at least 1 condyle. So I fix the medial condyle with the anatomical plate, and then I did the total elbow arthroplasty. So this is at 2 weeks, and 4 months is like this. Is the medial epicondyle is already healed, and this is the result at the 4 months. And also this is 3-year result, no recurrent infection. The patient is happy now. Okay, thank you.
Good job.
Thank you, Dr. Pornpanit, for such a wonderful case. Congratulations for your case.